And then Dr. Latassi probably talked about these on Monday, right, the vaccinations. All right, tetanus. So tetanus is an acute infectious disease caused by the spores of Clostridium tetani. So these are gram-positive anaerobic bacilli. And when you look at them on our slide, they have this drumstick appearance. The spores are found everywhere, particularly in soil, ash. Can be found in the intestinal tract, feces of animals, and in humans. And a lot of times when you think about tetanus, you think about dirty, rusty nails, right, or barbed wire. That's where most of the time when you think about tetanus, that's where they are. And so the spores usually develop bacteria that enter the body, usually from a puncture wound. A lot of times people stepping on nails, or someone, you know, getting across, trying to climb a wire, a fence gets caught on that. Because with the bacteria having the spores around them, it makes the bacteria very virulent. It can stay out in this environment and withstand a lot of heat and everything like that. And what makes tetanus different is it is vaccine preventable, but is not spread person to person. So who gets it in the U.S.? It's usually those who are not vaccinated, or those who miss their vaccination beyond 10 years. But it is an international public health concern worldwide, especially those in poor, poverty-stricken countries because they don't have access to immunizations. You can also, in a lot of other countries, you can get neonatal tetanus, where when they're delivering the baby, they're cutting the umbilical cord with like a rusty instrument, and then the babies get tetanus that way. Same with a mother. When you deliver it, you know, you can get it maternally because they didn't get tetanus vaccination. So basically, this Clostridium tetanus colonizes a deep wound, and just in a perfect environment, it will create a tetanus toxin. And then the toxin interferes with the release of the neurotransmitters that block inhibitor pulses. So basically, it leads to unopposed muscle contractures and spasms. You can also develop seizures. And other autonomic system, nerve systems will be affected. So basically, your body doesn't relax because the neurotransmitter is telling it to relax. It doesn't after a muscle contracts. This is just a nice little animation. Again, usually a puncture wound, laceration. Is how most of the people figure. So the incubation period ranges from 3 to 21 days, averaging about 10 days. In general, the further the site of injury to the CNS system, the longer the incubation period is. The shorter incubation period has more association with a severe disease. And it has a higher risk of death. So there's 3 forms of tetanus. You have the generalized, localized, and cephalic. So I want you to be aware of all 3 types. Signs and symptoms. So the most common initial symptom of someone with generalized tetanus is they get spasm in the muscles of the jaw. So that's why it's usually termed lockjaw. Then they'll get painful spasms, usually in their stomach, head, neck, area trunks, and then they can progress to seizure-like activity or convulsions in really severe cases. And in the cases, sometimes, depending upon the immunity of the patient, how severe their generalized tetanus symptoms will be. So if they have partial immunity, their spasms may not be quite as severe as those who have never had immunization before. And then you have localized tetanus. So that's, this one isn't as common, but it occurs when people have partial immunity. So it's usually mild, but it can progress to more of the generalized tetanus. And then the third one is the cephalic tetanus, and it's associated with lesions of the head or face, or it can be also associated with otitis media. And this is the rarest form. Usually the incubation period is short, usually 1 to 2 days. And unlike the generalized and localized tetanus, these people will have flaccid cranial nerve palsies rather than spasms. But it too can also progress to a generalized form. So the facial spasms usually produce a characteristic expression. So these people have a fixed smile, elevated eyebrows, usually are in pain, so they look like they're smiling all the time. Then they also get this characteristic where they add up their arms and their fists are clenched. I'll put you on the next one. So it's usually painful, generalized tonic spasms, and they sweat, they have profuse sweating. But a lot of times they're awake during all of this, but sometimes they can slip into a coma due to repeated spasms and seizures. So with this, sometimes when they're locked, especially babies or even like that gentleman on the right, when they're locked like that, you can cause, laryngeal spasms and you can cut off their airway. And babies usually can't cry out. A lot of times they have difficulty breathing, swallowing, and that's why you see a lot of drooling in these patients as well. This is like the classic picture of back in the days when you had tetanus. So how do you diagnose someone with this? So there's really no labs you can order. So according to the WHO definition of tetanus, it requires at least one of the following. So you have a sustained spasm of the facial muscle, in which the person appears to be grinning, like I said, or they have painful muscular contractions. And then, obviously if they have a history of a wound, but a lot of times people may not know that they've had a history of any wound or injury. And so these are just some differentials for tetanus. And so these patients require immediate attention. They need to be hospitalized. You need to initiate supportive therapy, make sure they have proper airway, and you give them the human tetanus immunoglobulin, the TIG. You give them benzodiazepines to control their spasms, and then if it's a wound, you you really want to debride the wound and give them antibiotics, and then you also give them a tetanus toxoid booster. Because the reason why you give them a booster is even after you recover from tetanus doesn't mean that you won't be able to be infected again. And therefore you would be immunized or give them a booster. Prognosis. So mortality worldwide is higher, again, because they don't have access to immunizations. In untreated adults, 60%. Neonates is even higher. Mortality is highest in the extremes of age, so the younger and the older people, and then also IV drug users. So IV drug users are at risk because of dirty needles. And then the respiratory failure is the most common cause of death. Like we said earlier, they can have laryngeal spasms, they can develop a pneumonia, and then they die. Being in bed, they can develop DVTs or PEs. And again, prevention. So tetanus is a preventable disease by getting vaccinated. Immunization is usually 10 years, and a lot of times patients will come in, they won't remember when their last tetanus shot is, and they don't have any record of it. So if they think it's been at least more than 5 years, I usually give them a shot. So obviously anybody, over 10 years old who end up having a puncture wound that they don't know of, definitely they need a tetanus shot. All right, diphtheria. So diphtheria is caused by Corynebacterium diphtheriae. It is a non-motile, non-encapsulated, glove-shaped, gram-positive bacillus. So back in the day, this was a major illness before the advent of vaccinations. Children were dying all the time. It said back in 1921, there were 206,000 recorded cases of diphtheria with 15,500 deaths. So starting in the 1920s when they did the vaccination, the numbers dropped. In between 2004 and 2015, there were only 2 cases of diphtheria that was reported in the United States. But globally, again, it continues to be a problem because no access to vaccinations. So how do you get this? From coughing and sneezing, respiratory droplets. You can also get it from fomites, contaminated items, cups, pinkies, things like that, towels, toys, and then you can get it from touching a contaminated wound. Those at risk, unimmunized children. So those, you always want to make sure when you're sending your kid to daycare that I would only accept patients or clients who are immunized. I had a friend who she didn't immunize her child or delayed his immunizations because she was afraid of autism. And then she says, then her pediatrician fired her. Because, they have that option. People think that they can just take their child into a pediatrician's office all the time, but the physician has a right to fire a patient because, think about it, you're unimmunized, you could get sick bringing that illness into other children there. So she was surprised that she got fired. Really? Are you really surprised? And you would think she would have because her child was a micro-preemie, so he was teeny tiny. So other people at risk living in crowded, unsanitary conditions, anybody who went to an area that's endemic in diphtheria. Again, rarely occurs in the U.S. or Europe due to vaccinations. So how do we get it? So the diphtheria colonizes in the throat. Humans are the only reservoir. So as the bacteria colonizes, it creates this gray, thin membrane. They call it a pseudomembrane. And it extends from the, if it's in the throat, posterior oropharynx, and it goes all the way down to your lungs. Sometimes, other diseases can cause a pseudomembrane, but the useful sign of diagnosing diphtheria is if you try to unhook the grayish pseudomembrane, and the tissue will bleed underneath there because it's adherent. Most other infections, that pseudomembrane really isn't adherent, it doesn't bleed underneath there. So then it happens, it develops a exotoxin, and the toxin enters the bloodstream, remains in the throat, and then you cough it and you spread it that way. And then it can affect other distant organs such as your heart, your kidneys, and your CNS. Incubation period usually 2 to 5 days, a range of 1 to 10 days. Like I said earlier, it can involve any mucous membrane, but normally it involves a respiratory. There's 2 types, respiratory diphtheria and cutaneous diphtheria. The ones we saw are there was only one case that we thought that this guy had diphtheria. He was a young man that went to the ER, presented to the ER with sore throat, lymphadenopathy, and they thought he had either strep throat. They treated him for strep, and he never cleared, came back, and I think we even did a monospotting him, and it came back negative. When you look in his throat, he had the pseudomembrane on the left tonsillar area. I don't think we tried to unmove it or not to see if it bled, but it was this gray, it didn't look like a regular strep, But he was immunized, is what he said. So I don't know whatever happened with him. It was right before I left. So again, signs and symptoms: sore throat, hoarseness. They have a thick gray membrane covering their throat and their tonsils. They may have difficulty breathing if they have a lot of swelling and edema. Maybe some nasal discharge, fever, chills, and malaise. So it can kind of look like someone has mumps or strep, something like that. But here's a picture. So see that pseudomembrane kind of has like a grayish appearance to it, and then that's the bull neck that they get. Yeah, that bull neck, that lymphadenopathy. And then this is the cutaneous diphtheria, which is the second kind, basically affecting the skin. So you get pain, redness, swelling. It almost looks like some other skin cellulitis. Almost looks like a chancre. Looks like almost like a squamous cell if you look at that picture. But again, they'll have this gray pseudomembrane on top of that that will develop over the cutaneous diphtheria. Again, we kind of talked about that, complications of diphtheria. So that throat gets real swollen, can block your airway, difficulty breathing, swallowing. Eventually, chronically, you have myocarditis, nervous system toxicity, and then they can also develop a pneumonia. Overall mortality is pretty low, 3%, but it's highest in those with either delayed presentation or to develop cardiac issues. Or, again, that spectrum, those under 15 and those above 40. So the young and the old have a higher risk of dying from diphtheria. How do you diagnose it? You get a gram scanning culture. And if it's a wound, take a little biopsy of that. Again, do it on the edges so you can get good tissue, normal tissue, and not normal tissue. With this, if you suspect it, go ahead and treat them rather than waiting for the labs to come back. These are other differentials, so mono, epiglottitis, angioedema, acute pharyngitis. So you would give them, how do you treat it? You give them the antitoxin and as well as antibiotics. So the antitoxin, you can give them IV for severe cases. You can also give it to them IM for some that are less severe. And then antibiotics, either penicillin or erythromycin. And sometimes if you give them antitoxins, you want to make sure that they don't have any sensitivity to the toxins. You could do, which I'm like, how do you do that? How do you do desensitization to the toxin? Give them a little bit at a time to make sure they don't have any reaction to it. But those people would have to be hospitalized and inpatient for that. Well, yeah, you keep them isolated until I think 48 hours after they've been on antibiotics. And then for the cutaneous diphtheria, you want to make sure you clean that out, debride it, and give them antibiotics as well. And the same as before with the tetanus, you want to give them a vaccination or a booster after, because again, having it doesn't make them immune to having it again. And then those who are in close contact, you want to check them. They should get a booster, and then you want to recheck them, and if they ever develop any signs of diphtheria, then I would give them the antitoxin. And then once a patient is done with their therapy, I would come back and culture ×2 to make sure that they've cleared their infection. Again, prevention, very preventable disease, is to get vaccinated. And then Dr. Latassi, I'm sure she talked about the different types of vaccinations. Those are all listed there. And she gave you guys the when to give it, how many doses, that kind of stuff, right? I think sloths are so cute. You don't think sloths are cute? It's the longest thing in the world. Have you seen, do you guys watch Ellen and see Kristen Bell?
Yeah.
Where she's obsessed with that sloth? I was like, oh my God, she really loves sloths. I'm so happy. I know. And then botulism. Anybody anybody's family canned foods?
This is a big problem in Alaska because a lot of the native communities get salmon and can it, and then if it doesn't preserve right. So it's I think it's pretty, I don't want to say common, but
Right.
I've always heard about it.
My parents never canned food. I've never eaten like home canned food. So botulism. So it's a rare, again, but unless you live in where people like to can their foods, serious life-threatening disease. Again, it's caused by a toxin that attacks the bodies. It's an intoxication rather than an infection. You ingest botulinum toxin formed in canned foods. Again, this one does not spread person to person. So again, it is produced by Clostridium Botulinum. It's an anaerobic, gram-positive, rod-shaped bacteria. And the spores, they grow anywhere in the soil, lake sediments. They're found in plants, so a lot of times when bees go from, pollen or collecting pollen, so that's how they usually get that, and then they take the honey, and that's why eventually, we talk about it, but you don't give honey to those kids that are less than 1 year old, because that's how they get it that way, from the bees. But it's also found in the U.S. and around the world. And again, the spores are heat resistant, and without the oxygenation, they are allowed to grow and survive in the environment. So sometimes people can actually eat the spores, but it's not enough to make them sick. But under certain conditions, like I said, they can grow and make it and start developing the toxins in the body. So there are 7 forms of botulinum toxin, A through G. Some, if you read some things, it'll say 8, because the C, there's like C1 and C2, but these are ones I just want you to know that A, B, E, and rarely F can cause human botulism. Most of the foodborne ones are caused by the type A toxin. And then C, D, and E cause illness in birds and mammals. Again, we kind of talked about it. There's 3 naturally occurring forms of botulism. The first one is the infant botulism. It's caused by ingesting spores in honey, usually. And then the reason why they do get it, because their intestines aren't fully developed yet to fight the bacteria when it reaches into their stomachs like adults can. So that's why under 12 months of age, you don't give honey to babies. And then foodborne botulism, like we talked about, is caused by eating foods that are contained home canned that develop the botulism toxin. And then wound botulism. So the spores enter, breaking the skin and cause infected tissue. And then there's inhaled botulism, and that's using that as a bioterrorist attack. So it does not occur naturally. So if you see that, if someone gets it by inhalation, it could be a sign of bioterrorism. So home canned foods. So it's usually when you can low acidic foods, like asparagus, beets, corn, salmon. Maybe salmon's low acidic. I'm not sure. And then back in 2015, home canned potatoes were the largest U.S. botulism outbreak in nearly 40 years. That was kind of interesting. But that's why they recommend you use pressure cookers when you can foods, because it can reach a higher temperature than regular, just plain old boiling. And then honey ingestion, like we talked about, the honeybee. And again, not recommended for babies less than 1 year. And then crush injuries or injection drug uses for the wound ones. So the incubation period for the ingestion for the babies is kind of unknown, because unless the mom's really making sure when the baby might have gotten honey, it's kind of hard to say when the baby had the ingestion. So that's kind of hard to tell for incubation life. For foodborne, it's usually 4 to 36 hours. Wound, 4 to 14 days. then inhalation 24 to 36 hours. So like we kind of talked about already, the toxins enter the bloodstreams, binds to the cholinergic nerve endings, so it blocks the release of acetylcholine, preventing muscles from contracting. So this one, you get the flaccid paralysis rather than contractures. So usually this presents as symmetrical, descending, flaccid paralysis. So death in botulism usually occurs as a result of respiratory distress. So airways get obstructed, or you also get secondary infections like pneumonia from prolonged ventilation in ICUs. Anytime someone's in an ICU, you always have a risk of getting nosocomial diseases. So signs and symptoms. So more than 90% of patients have 3 of the 5. So they have nausea, vomiting, headache. They get the droopy eyelids, fixed pupils, blurred vision, and then difficulty swallowing. Babies can get floppy baby syndrome. They may have a weak cry, poor feeding, and poor muscle tone. So that patient, the guy at the top, you can see him smiling, but you don't see any wrinkling of his eyelids. You know, like when you smile, you can get that wrinkles on the side, kind of really small, kind of fake that you can't really see him doing. That's his maximum smile. You can't really tell, but he's got dilated pupils, the droopy eyelids, and then that kid at the bottom too. He raises his eyes to open. And how you diagnose it, you can do a toxin bioassay. You can sometimes do an EMG to rule out other causes of paralysis. But most of those, like you think of, some of the differentials might be Guillain-Barré, but it would be ascending, right, versus descending. You can culture the toxin in serum, stool, vomit, any suspected foods they bring in, maybe stool cultures, wound cultures if it's a cutaneous. And treatment, if they're greater than a year old and then in adults, you can give them the botulinum antitoxin. It's a heptavalent. Again, making sure they have proper airway, body positioning to help decrease the risk of respiratory failure, and then give them either a PEG tube or NG tube to feed them. And an elimination of the spores, you can try to induce diarrhea, give them a high enema, induce their vomiting, and if they have wound botulism, give them antibiotics for that. Usually IV penicillin or metronidazole. And then if they're in the hospital and they're, because they're going to be in bed, you got to watch for pneumonias, DVTs, UTIs, things like that. And so those are just some of the differentials. So botulism prevention. So when you do have someone that you suspect has it, you want to notify the public health authorities. Again, strict canning techniques using the pressure cookers. Again, don't give honey to babies less than a year old. And then if someone who gets a wound, make sure you clean it out to prevent any infection there. But there's no vaccine currently licensed for public use. I think they've got some type of vaccine that's indicated for high-risk lab or military personnel. I think it's like a secret vaccination. But they're like multiple injections. You have to do it like 4 times. But most likely the use of this won't ever happen in the civilian population. And then there's therapeutic uses of botulism toxin. We used to use it a lot for patients who had dysphonia. So you ever heard spasmodic dysphonia? You ever heard people talk like Catherine Hepburn used to have that kind of voice? We would inject them with Botox. You know, obviously people use it for cosmetic reasons, also hyperhidrosis, you can use that as well, Botox for that. People who suffer from migraines, they use Botox a lot for migraines. And then torticollis, they've used that in the neck, injected in the neck for that as well. The only thing you worry about sometimes is having a bad reaction to Botox, you know, if you do it for cosmetic reasons. I think there was a local physician here, it was been years ago, she got a Botox injection and she actually got toxic from it. And she no longer could work she was an OB, she was a surgeon, so she could no longer work. I think she actually sued Botox because I think it was something in the consent form that they left off. I don't know, there's some way, but she wanted millions of dollars from that. But I mean, she lost her career over it, you know. So just be careful when you decide at that time, if it ever comes, that you guys want Botox, just be careful. You may look like Joker, or you may have droopy eyes, one or the other. So,